Evening, everybody. If anybody's joined us, there's a few people I think already there. So just wait a few minutes just while we're getting started. Just wait for a few more people to join us. If you give us a few thumbs up and things so we know that it's working okay, that would be good, as we're not experts by any means. I won't say this is my 5th attempt this evening.
It is.
First week was 3 attempts, last week was 2 attempts, and this week was 5. Oh well. Right, we're getting a good few people joining now. Hopefully people can put a few thumbs up and things and let us know that they've got us okay. Yeah, we're getting a few likes. Okay, so this evening, guys, so welcome again to join us for week 3 of our enthusiastic late night ultrasound webinars. It's the usual crew of myself, Dave and Rob, and we're delighted tonight to have Douglas Ogg from Orca Medical join us as well. We've been working with Doug now for, well, probably year, 2 years, I guess, Doug, probably seems like longer for you. He's become a great friend, and we've had a fantastic collaborative relationship with Orca around the educational courses that we run. Doug is an absolute fountain of knowledge when it comes to ultrasound machines, systems. He's worked in the industry for many, many years, and so we're very, very lucky to have him with us tonight on this webinar. So thank you very much, Doug, for giving up your Thursday night to join us on this discussion tonight.
You're welcome.
Just to start off with, we're going to try and just sort of cover, I think, a few of the basic things. And we had a discussion this evening briefly before we came live, just about what is a good starting point for this discussion. And one of the things I felt, I think some of the other guys felt, was that it was quite useful just to understand what are the different types of ultrasound machines out there. When I started thinking about ultrasound and was involved in learning ultrasound, I had no idea what different types of machines out there are. And I think some of the times people can imagine that an ultrasound machine is just an ultrasound machine and they're all the same, but it's anything but that. Doug's cat has made an entrance already. What I want to do to start with, just to sort of set the ball rolling, is just to share a few graphics of different types of ultrasound machines, I think, as a starting point. So if I bring this up, hopefully you guys will all be able to see this. So there's a number of different machines out there, and we'll go through these in more detail, I'm sure, and I won't sort of hang about on the slides too long, because it's much better, I think, that you see us all discussing things tonight. But you've ultimately got handheld systems, which are a massively developing area in and around ultrasound. So handheld systems can be wired, can be wireless. That's one option that's out there at the moment. I'm now going to slip on a side. There we go. There's laptop systems, so portable laptop systems, if you like, the next level up, if you like, from a handheld system. And then there's also cart systems. So if you like a more higher end cart system, and it's probably worth me also mentioning that within laptop systems, you've got a real spectrum of different types of laptop systems, maybe some lower end and maybe some that are slightly higher end. So you've got this spectrum of ultrasound machines. I'm going to come back out of that so that we're not sort of hanging around on PowerPoint slides too much tonight. But I think it's useful just to start off with, to sort of say, as a starting question, how on earth does somebody decide what ultrasound machine they should choose, guys? What do you think? Drop that bombshell.
Should I go first?
Yeah, go for it, Dave. Yeah.
Yeah, you know most. That's
White band man of ultrasound.
Dave Baker.
I would say, from a very sort of, practical perspective, obviously the biggest thing is money. So it's going to be your budget. It's going to be what you are likely to use it for. If you're obviously working in private practice, how are you going to monetize it? If you are working sort of more NHS space, and a lot of it, you know, may be around the sort of practicalities of the environment and the context within which you're going to use it. And then obviously you need to think about sort of, you know, the image quality, image capability, which I'm not going to attempt to go into. I'll leave that to the likes of Doug. But just in terms of what you can visualize, the breadth of what you scan in your daily practice and what you can realistically visualize well on the machine. And obviously the practical elements such as, for example, I work between various different clinics. I need to be able to carry my ultrasound around with me. And certainly when I was learning, and I think this is a really important consideration for people, is when you're learning, you want it with you 24/7. You do not want your ultrasound machine locked away in your office that you may only spend a few hours in every week. And realistically, you're not going to sit back for hours every night practicing. You want to be able to take it home, and you want to be able to chase anyone who stands still long enough for you to scan them. So those are my key points.
Yeah. Yeah, for me, I would say reliability. I think if I kind of look back at, you know, when we first started scanning, and I look back at the kind of scanners that we've been using over the years and stuff, then I think there's definitely, there were always these machines that everyone sort of gravitated towards because they were kind of like robust, they were portable, they were not too expensive, which obviously makes a big is a big decision maker, particularly when you start out. But it was that sort of combination of things, and word of mouth, obviously, because you speak to other people who've already used machines, and then you kind of suss it out. And particularly when we started, which is like 12 years ago or so, I mean, the quality of the machines, I think, the laptop machines, I do very, very vividly remember that in an intro course, there were a couple of reps that brought a laptop machine, and there was the system crashed a few times as they were demoing it, and I thought, oh gosh, you know, this is probably something that might be a problem. And I think as time has progressed, it's all changed now, and the machines have become a lot better. So maybe it's not, there's a lot more to choose from, but the choices were quite limited in the beginning. So and it was then costs, and it was a sort of combination and durability aspect to that, and that meant that the options were quite limited. Yeah. But I think that there are a lot more now. So,
Doug, some thoughts?
Well, I think the most relevant thing that I picked up there is you know, is the thing about access to machines, because if you're working in the NHS, then there's probably going to be a machine that you can find. The question is it an old one? You know, if you go to your EBME department and in the hospital, they'll probably find you a machine, but it's probably been extremely well used. Yeah. And it's a hand-me-down. Someone's just got a new machine, so this has got a little bit more legs in it. And it could have been used for almost anything. So is it appropriate for MSK?
MSK, yeah.
Then in private practice, you've got the problem, you know, if you're, or in the community, if you're working in a place that doesn't already have ultrasound equipment, old or new, that you've got access to, then Dave's point about cost is really, really relevant, because, you know, how much do you have to pay to get something that's realistic and worth it? And you know, the truth is there's an awful lot of hype at the moment about handheld ultrasound scanners. You know, this is new technology. It's really exciting. It's opening out the use of ultrasound for, you know, the place of use of ultrasound extremely widely, both within hospitals and outside, you know, and the prices can be very, very low. So it's really attractive for you to want to buy it.
Is it worth us just thinking about, you know, from an MSK perspective and the handheld systems as a starting point? You know, I'm sure a lot of individuals, as you say, Doug, are looking at themselves saying, okay, the price point is much better. Potentially, it's attractive, the price point. Is that something that's suitable for me to use for MSK practice? Again, and to the other guys, what are the pros and cons of handheld systems?
Pros and cons. Well, I think, the cons are obviously the quality and the resolution. I think everyone would acknowledge that's obviously is compromised, and it means that it has a much more limited, I think, application, and particularly in MSK. I can understand, of course, there's widespread use, as Doug will know a lot more about, in other areas, and particularly in acute medicine and for vascular applications, etc. But in MSK, I think that to me is one of the barriers.
I guess that comes down to, and what we're talking about here is that the handheld systems tend to have, am I right in saying, a lower frequency overall?
Yeah, I mean, at the end of the day, a handheld system, the scanner, somewhere, whatever they connect into, if it's a mobile phone or a tablet or whatever else, that's all you're using that to do, is to display the image and act as a control surface. Yeah. And all the processing has to happen on the probe. And there's a limited amount of space, and inevitably someone who's looking at buying a probe is going to pay what they think is relevant for a probe. Then you've taken away the scanner, so they're not going to think about how much that costs. Mm-hmm. So you've got several challenges. One of them is, one of the most relevant is space, because as anyone will know, why do laptops have cooling fans in them? It's because the microprocessor inside them works quite hard and it gets hot, and you've got to get rid of the heat. So things like that actually have a big impact on how the thing works, and that's practicality. But making something for a particular price is really important, because you've got to hit the customer's expectation of how much it's going to cost. And then you've got to start thinking about how suited it is, what it's been designed to do. Now, if you're working in point of care, emergency care medicine, you actually need a device that can do several things. It needs to be able to scan a heart. It needs to be able to scan an abdomen. And you'll need a linear style probe, which is the type that you use for MSK ultrasound. You'll need that for vessel access. So if a probe has been designed to fit all those three, the question is how well it will suit.
Oh, we just lost Doug there a little bit.
Designed for MSK.
Yeah, I think we just lost you there a little bit, Doug. And I guess what we're kind of coming on to here, aren't we? We're thinking about having something that meets the requirement of what you're going to actually use it for in clinic, aren't we? And with MSK, obviously a lot of the structures can be very, very superficial, require higher frequency, better resolution. But at the same time, if you think about, and I'm thinking here maybe big tendons, gross changes in tendon structure, Achilles rupture, quads tendon rupture, patella, big tendons that have gone. Actually, sometimes maybe that the lower frequency probes are able to say yes, it's gone, or no, it hasn't gone. And so so I think what I'm keen to sort of people sort of say, think about how it's being utilised in your practice and what you actually need from a system. And the handhelds may have a role to play in some domains, but you need to know where you work and what you need it for, ultimately.
Yeah, totally. Yeah. Because I remember that there was like an evening session that I did some time ago, and I know Doug was there as well. And this was, yeah, he saved the day actually, because we didn't actually have a projector, and then he managed to sort of pull that one out of the bag. It was great. But yeah, and I did a demo on a hip, and we had a Sonon handheld, and I have to say, for it was a reasonable size hip, and it was actually a really nice image, and not an awful lot like less resolution, I would say, than like your average like higher priced machine. So and you know, portable, or even
that's a common misconception, isn't it? Because the handhelds are actually low frequency, so they're actually for those deeper structures. Oftentimes people have this misconception that they would be only good for superficial structures, but because they're low frequency, that's actually the opposite way around, isn't it?
And ultimately, there is much more to it as well, which I'm sure Doug is thinking, than just the frequency. And we kind of touched on this before we chatted, didn't we, about maybe it's not so true with the handhelds, maybe more with the laptops, but I've certainly had systems that are identical systems with the same probe. We'll deal with probes and frequencies later on, maybe, and the image quality is very, very different as well. So there is more to it than just the software behind it. There's more to it than just the frequency of the probe.
Yeah. Could I say also, and again, I say this very much with my private practice hat on, but I'm aware that a lot of people, you know, if they're thinking about sort of point of care ultrasound, they might be working in the sort of private sector, independent sector. There is a little bit, to me, there's a little bit around patient expectation as well. Like when a patient comes in to see me, even with my sort of, you know, laptop, then you know, portable machine, then oftentimes they're sort of looking around the room, oh, where's the ultrasound machine? Where's the ultrasound machine? And you're like, oh God, I thought that was a laptop sort of thing, you know?
Yeah.
I've got to say, I've been absolutely 100% on this, but why wouldn't we be when we're having a conversation like this? There is a little bit of me that thinks it needs to look the part to fulfill patient expectations. And I think until people almost expect to see and accept these very, very small devices, there's going to be a little bit of me that will be reluctant to get one just purely on the patient expectation, if I'm being perfectly honest with you.
Good point, yeah.
It's a good point. I mean, when you think about it, where do most people in the general public, where do they see scanners? Yeah. The most common place they'll see a scanner is in an obstetric ultrasound department.
Yeah. So patients oftentimes say to me, wow, I was expecting to see the thing that I saw when I had my baby scan, sort of thing. You know, God, wow, you know, things have moved on, sort of thing. But there's a balance, isn't there, when they go, are you sure that's a proper ultrasound machine?
Anyway, we've had a question coming, guys, from Masrianu, who's just said, so what are the frequencies that bring a good image resolution for MSK ultrasound? And he sort of suggested 6 to 16 megahertz to sort of start us off.
Good question.
Yeah, great question. Thank you. Keep them coming.
Dave, what do you think?
What do I think in terms of range for ultrasound? Well, I think
the frequencies.
Oh, it's like you were saying before, isn't it? There's the probe, but there's also the machine behind the probe. So that's something to be considered. So there's only so much you're going to get out of a probe if what's under the bonnet's not sort of backing it up. And also it depends what you are looking to scan. Obviously, if you are going to be looking at sort of structures where you need that sort of higher frequency and you're going to benefit from that higher frequency, then great, because obviously the higher frequency is going to give you the better image quality to an extent. But again, you know, as you say, people oftentimes overlook some of the, you know, benefits of, you know, having good sort of lower frequency as well. So I think, are we asking, is that range adequate, or?
Well, yeah, just a general question, I think, is what would bring around a good image resolution. I mean, it's interesting, Doug, isn't it? I mean, probe ranges, they obviously the frequencies seem to have gone up over time in terms of, you know, they started off being 13 megahertz as the kind of the top end frequency for a linear probe. Now it's sort of creeping up. We're talking about 16, but certainly 18, sometimes higher.
But I think that you're right. And we are using systems that go up to 18 megahertz, like the normal linear probe. But we also have used systems that were, you know, not necessarily in terms of their resolution an awful lot worse that were max out 12 megahertz. And I think, I mean, that's sometimes a bit difficult to understand for people, because if you have a range from, let's say, 3 to 18 or like 6 to 12, I don't know, like for a lay person, you would say the one with the biggest dynamic range and the highest frequency is the best probe and produces better quality image. Is that, I don't know, is there anything in that, Doug? Because like, why are some probes a very small range and relatively low, and others have that huge range, and is it an expense? Is that a cost thing as well and stuff, or is that?
Well, this is about the importance of matching the backing. You know, you have to look at a probe and a scanner as a system, and it's how the component parts of that system will work together. So if you just take the frequency of the probe, then you're only looking at one aspect of what is important in looking at the whole image. So when you move to higher frequencies and using higher frequencies, what's the one thing that you learn about high frequency ultrasound? You're taught this very early on. High frequency ultrasound attenuates. So if you're going to use high frequency ultrasound to build the image, then you need to make sure that your electronics, the front end, the probe, etc., are really sensitive to that high frequency so that it can actually be used. Mm-hmm. Then you've got to think about the actual power of the processor, because when you are listening at high frequency, there's more information there. So you've got to have a more powerful processor to be able to utilize that high frequency and build an image out of it. Mm. So don't expect...
It's like having a PC. Yeah, so it's like having a PC with, you know, high-level graphics software on it or something. You've got to have a decent enough processor to run it.
You want to have the best graphics, get a gaming PC.
Yeah,
with you know, you spend the money on the graphics card, and the drivers for the image, and that's exactly like ultrasound. You know, you've got to match all these different components together and actually make them work for the desired need. Mm-hmm. Now, you know, if you're really focused at high frequency imaging, then you can make a fantastic scanner. But the reality is that most scanner platforms, cheap ones, are made for a multitude of applications. Mm. So, you know, whether it's a laptop or a cart-based scanner, cart-based scanners aren't that much more expensive. You know, there are lots of very cheap cart-based scanners out there that are similar in price to a laptop. I mean, you know, think about computers. You know, how much does a desktop cost compared to a laptop for equivalent performance?
I think that's another misconception, isn't it? Because the cost of an ultrasound machine isn't in the cart, is it? No. So the idea that a cart-based ultrasound is fundamentally more expensive is just a misconception, isn't it? Because that's not.
And let's face it, when you're designing an ultrasound scanner, you're designing it to do all sorts of things. You know, if you call up that the slide you've made up, Stuart, I know those images were just downloaded. You went and did an internet search, and you downloaded those images off the internet. Lots of different scanners. They're all publicity shots. And look at what organ is on the front. Are there any with an MSK structure on the front?
No. Yeah. Well, maybe on the left or not. Can't
no, that's a thyroid, I think.
Oh yeah, is it? Okay, sorry.
There's your laptop system.
You know, there's a heart there. There's an abdomen. One in the middle, I can't really tell what it is. It looks as if it's got some elastography. They're trying to show a feature there. The one in the top right-hand corner might be MSK, but it's a low-res capture, so you can't really tell. And the other ones are vascular. I mean, that tells you the breadth that these things are doing. You know, every single scanner pretty much that you are going to be looking at is designed to scan the heart, it's designed to do obstetrics and gynecology, it's designed to do general abdominal, it's designed to do small parts, including breast ultrasound. And where does MSK fit in all of that? How much of the investment in designing that product has actually been put into the tailoring it for MSK?
Yeah.
And that's one of the reasons why, if you want decent MSK performance, for the most part, you have to look at a big, expensive scanner to get really high performance.
So if you're starting out, this is one of the questions that Stuart Kerr sort of asked us earlier this evening as well, was he said, what are your thoughts on machine requirements then for novice sonographers or trainees? Because obviously there's an issue here, isn't there, about access, and we're all too aware of that from an educational perspective. Is that to learn ultrasound, it's a tough skill to learn. You need access, but you also want something that's going to help you learn. And what you don't want to do is commit to something, purchase something that you just see out of panic, or I need to get something to get hands on and start scanning, because you may purchase the wrong thing. So I guess, what are the requirements, he said, and how do these change as your skills develop? So as you become more experienced, how is the need for your system, or what sort of system do you need? How does that change over time?
It's a really good question, that, because when you think about it, if you are a real beginner, you know nothing, then you've got to learn probe handling skills. You've actually got to learn,
a lot of it's about image optimization.
Probe, how to, don't worry even about image optimization. You just got to learn how it actually sits and what you're doing. So, think about cutting across a structure and cutting along the structure. That fundamental skill, which you have to do almost automatically, is to transfer from cutting across to cutting along and back without drifting.
Yeah, so
that's a fundamental, and you could choose the worst scanner in the world and practice that.
Yeah, and so I mean, when I think back, I certainly didn't use the highest spec sort of Rolls-Royce scanner to learn on. In some ways, I kind of feel like that sort of helps you build or refine your probe skills and that dexterity of what you're doing better. And so, it brings us back to sort of things like handheld systems and things. Are they a good way for somebody just to start out, to get access, get hands-on, and just to start to, we're not talking about the refinement of diagnosis here. We're talking about just visualization of things, understanding a grayscale image at a basic level.
I think they have a role there, but the problem is that you soon run into the limitations, and it becomes easier. It is much easier to pattern recognize, as you guys have know. You know this from the courses that you run. You look for good quality machines because you've learned that once someone's actually got a little bit of experience about what an ultrasound image is and how to hold a probe, they find it easier to learn structure with something that gives a good image. And that it helps them to learn to have access to something that's got a really good image.
To stitch the anatomy together and
correct
all that stuff.
Then once you have achieved what one might term a high degree of proficiency, you can actually use almost anything and get value out of it. Because you have so much experience by then. That's like putting, I don't know, what would be the example? A really experienced musician can get a really bad piano to play a good tune. But if you are not really experienced, you're not going to get a good tune out of a bad piano.
You also know what you're looking for, don't you? If you're an experienced sonographer and you use a lower spec system, you just have those built-in signs and appearances that you're tuned into, so that you can still draw out information, not in the same way perhaps as a really high-end system, but you can still draw that information out. You can still orientate yourself. I think that's the key thing, is you can still highlight types of structures to orientate yourself better. And I think the challenge with the handhelds for me at a very kind of beginner level is if the resolution of the image isn't as good, is the ability to, it's about calling out a tendon from a nerve, it's about making those differences that are so critical at that stage to build the understanding, the anatomy, the blueprint, processing around it. That's the challenge. That cat's back again, isn't it, Doug?
Yeah, she's back. She comes over and wants to say hello.
I think there's a balance of that versus, again, just the opportunity to practice and to learn.
Yeah.
So I would say, that if and it's so much of it comes down to the individual person, doesn't it? How do you learn something? I know when I'm learning something, I just need to carry it around with me all the time and practice 24/7. That's what I like to do. So if I'm advising somebody, that's how I like to learn something. There's no point having some fantastic cart-based system or something at work that you only get to, get your hands on for a few hours a week or whatever. What you need to be doing is going and practicing, scanning yourself and, this, that, and the other. And so to me, these in the context that I would be learning it or look to learn it, I can see that they've also got advantages in other contexts within which they might be used, point of care and sort of field usage and stuff like that. But I think in that ultrasound learning journey, that is where I would see it sort of coming in. So you lose a little bit in terms of, as you say, the sort of image quality, but you gain something in just those hours and hours and hours of practice, and that can go for the laptop-based system or sort of handheld system. And I think that's the really key thing for me. Those things hold.
Is it?
Yeah, no, I agree. I mean, it's, like I remember when we first learned ultrasound, and we were sitting for hours on end, like trying to follow a tendon, trying to turn on it and make it look good. And, those sort of skills you can do with any machine. They don't have to be great quality. And finding a vessel and that kind of stuff. And it was just following a nerve. As long as you can identify, like you said, if you can differentiate those structures, and I think in most handhelds you still can do that at a wrist, for example, then there's a huge amount you can get on with practice. And those are the skills. So to be honest, the scanners that we use, and we had these big card-based models, I mean, are probably, looking back now, in terms of image quality, probably not hugely better than some of the better handheld models. And it had massive limitations, of course, but we did learn on it, and we did.
Rob, I think that one of the things which is difficult, particularly if you're a practitioner in practice, one of the problems is that your confidence in what you're seeing is really important. How you call something is important in this. And you guys have loads of experience now. And you can be confident in what you're seeing because you've got this library of experience behind you. And you're drawing on all that experience whenever you examine someone. Another cat.
Oh, a cat.
Dave, you'll get your dog out in a minute, won't you?
I'm going to see all these cats in a minute and go mental.
And Stuart's going to get his kids out and we'll be a family. But for many people starting off, you've got to monetize. In a sense, this is your income as well. Dave's point about having to pay for something is really important here. And how do you become confident? And I think your journey to confidence is faster. And I think one of the things that's really important to bear in mind in this is that it takes a long time and a lot of practice with ultrasound before you feel really proficient.
And alongside that, that's probably nice time to take the conversation on to how do you justify, I'm talking thing here more about point of care people, but clinicians, how do you justify that expense of purchasing an ultrasound machine? Dave, you might be well placed in from a private practice point of view. How do you justify that purchase of the machine, the time of the investment of using it, getting that skill? That's a challenge as well, isn't it?
It's very different. It's very difficult in private practice, and it's something that we get asked about, obviously, loads by other people working in private practice, particularly. And that is, how did you sort of almost from a sort of business business planning perspective, how did you sort of justify it? How did you work out your numbers on it, sort of thing? And it's very difficult actually, because obviously when you're using in private practice, I certainly never have, and I know lots of physios don't actually charge any extra money, any extra tariff. Insurance companies won't pay you for an ultrasound machine. So really you're using it as an adjunct to what you do. So it doesn't actually have a direct monetary benefit, and obviously, to begin with, and this is it's tough to train in private practice, because the patients coming to see you, they're paying good money for your time, and they don't want you practicing to use a machine on them particularly. So if it's not going to add any benefit to their consultation, so really it's a very tricky one, because you're taking up their time. You can also as well potentially sort of slightly almost like undermine the sort of patient relation, the patient physio relationship, if you start saying, I don't really know what I'm doing with this, but do you mind if I just sort of wave it over you for a few minutes because I'm learning? Very, very hard, very, very difficult. So I was lucky enough that I was working sort of partly in the NHS through the real sort of like learning phases, and so I didn't have to completely learn from scratch in private practice, but I know many people that have, and it is very, very difficult, and you have to choose your patients very carefully. You have to explain to them that you're not a qualified sonographer, and you either might need to make their consultation a bit longer, or something, because ultimately you're taking up their time, and working in central London, people haven't got time. So
and what about, one of the questions we got asked about this as well was, should I purchase something or should I lease something? And I guess we could chuck into their considerations around warranties as well. Doug, I don't know if you've got some thoughts around those aspects.
I think for me, this is, if you take purchase or lease or any of these other, anything like that, it's a form of, in essence, it's a form of hire purchase. So you're paying for the scanner over a period of time, and you pay a little bit extra over that period of time to spread out the payments, just like buying a car or anything like that. With interest rates so low, then it often makes sense to do that, because it allows, particularly if you're in practice, it allows you to break that cost down into something that appears more manageable, and that's its real advantage. I think one of the things that's important here is that as you go through your journey learning, you're inevitably going to want to graduate to end up with a really nice machine. The question is how you get there.
Yeah.
And as long as you can actually have decent consultation and can see a pathway of being able to get there, then that to me is a good. The difficulty, I think, is that people often think, well, I get this one machine and I'm not going to be ever changing it. Now that's fine if you've gone right to the really, really nice machine at day one. And if you can afford to do that, do it, because actually
unlikely, I guess.
But it's a big investment.
Yeah. Yeah. And what about warranty on systems?
Warranties. Warranties, you know, basically anything sold in this country has to, there are laws around it. It has to be fit for purpose, and it has to, it actually has to be fit for purpose and to last in law for 5 years. Okay. So warranties that companies offer are a bit different, because what they're covering is against defects in manufacture very often. And often the manufacturers offer a more limited warranty. It's complex. That gives a lot of leeway for companies to actually turn something that's actually a right into something that's an exclusive benefit from buying from me, so to speak. And that warranties, yeah, they're important, but fundamentally, electronics is pretty reliable. Electronics will either fail quite quickly, or it'll start failing when it gets very old. The risk parts are the probes.
Yeah, I was just going to ask you that question, Doug. So I know we've discussed this before, and I was fascinated as a complete novice to this area about your discussion about probes and, you know, the cost of probes and the difficulty to replace them.
And yeah. Doug, would you mind just going through a bit of probe anatomy, because I find this really interesting as well. When we're talking about, you know, the number of wires that go down the number of lines that are going down the wire from the probe to the machine. I think it's really important for people to understand why that's so fragile. If you run over the lead or whatever with your machine, or if you damage the lead into the probe, why that's such a problem.
Okay. I mean, the cable is actually one of the more critical parts of the whole machine, of the whole system, because it has to carry the signal back from an echo signal, very, very weak. And it has to carry that signal faithfully back without attenuating it too much, without losing it, from the element in the probe all the way back to the connector at the end, and then into the scanner, which is where the processing happens. Once it's digitized, that echo is digitized, then it's easy to handle because it's just numbers. But up until that point, it's analog and prone to all sorts of physical effects. Every single element in an array has to be connected by a wire to a connector that goes back into the machine. So what looks like a fairly simple cable from a probe is actually hundreds of tiny wires. And each of those wires, high frequency electricity, has a tendency to leak. Goes in a wire, and that's why, for example, from your aerial, the frequencies are similar to the frequency of your television aerial, of the signals that come down your television aerial. And you have a great big thick coaxial cable to do that. It's a coaxial cable because a coaxial cable is a design that keeps the signal inside the cable. If you don't have a coaxial cable design, then the signal will leak out and it'll disappear. So every single of these tiny cables inside the probe cable has to be a coaxial cable to stop all the signal leaking out everywhere else.
Which is why it's so important to look after your cables.
Correct.
Because I've seen people with their cables just tied around in knots. I remember Rob used to do that when we were working together.
I thought
Still does.
Use it as a skipping rope.
I thought, when are they going to kind of bring this up again?
Rob actually needs a Kevlar cable, I think. Do they exist? A Kevlar Rob Mars cable? I don't know.
Rob Mars resistance. Yeah.
I mean, there's a lot of shielding that goes into them. Now, the other thing is that people complain about the weight of cables. And
you feel it when you're scanning sometimes, yeah.
You know.
You're a delicate little flower, aren't you, Stuart?
Delicate little flower. But these things are also, you know, if you take a hockey stick probe, yeah, hockey stick probe is a short array. It's a high frequency array, but it's a short array, so it has fewer elements in it. That means that
that slide with the probes on, just in
Yeah,
case.
yeah. Let me get that up. I'll leave that up for a second, Doug, or you can talk through probes. Hang on.
Okay. Get to the probe. Can't really see the cables there, but the cable on a hockey stick probe, because the hockey stick array is short, there's no scale on this, so you can't really tell that it's a smaller probe. But the array front of the hockey stick is about half the length of the two probes next to it. So those are double the width. Yeah. Now that means that you've got to have, for those two probes, for the same number of elements, you've got to have double the number of of tiny wires in the cable compared to the hockey stick. Or you've got to have fewer elements in it. And the one way of making fewer elements is to have a lower frequency probe, because for the same width of array, for lower frequency, there are fewer elements in that width. So all these little tricks come into it.
And in terms of MSK probes, there's a couple of different linear ones there, aren't there, in the middle, and that'll be something that people encounter when they're purchasing, is different ranges for linear probes.
Yeah.
Is it worth just touching on that, guys? And which now, do you need more than one probe? Silence.
Again, personally, I would say it depends, in what context you are working, and what you're predominantly seeing. I mean, I would say that 90% of what I see, then a linear probe with a decent range on is absolutely fine. I'd love to have a Curve linear probe for the odd hit that I see, but I just don't see enough of it to justify it. Curve linear probe, comes in at what, sort of 4,000, 5,000, 6,000, depending on what machine you're working on.
Yeah, generally speaking, Curve linear probes are a bit less expensive than a high frequency linear.
Okay, so maybe a little bit under that. And again, I'd love to have a hockey stick. I see loads of hands and feet, and do lots of injections around hands and feet. I'd love to have a hockey stick probe, but again, it's just sort of justifying the additional outlay. I had a hockey stick for years, or I worked with, we had access to a hockey stick for years, and they're so lovely for doing like hands and feet and doing injections on small joints and everything. Fantastic, but again, they don't. There's not much that you really can't do with a linear probe that you can do with a hockey stick. Yeah. It's just a lot nicer and a lot more comfortable.
As long as the linear probe isn't too big, because I think bulky linear probes are really difficult to use for small joints.
Yeah, and if they've got a great big sort of blind spot at the end of the probe as well, certainly, some probes, I don't think you get it so much nowadays with the modern probes, but they used to have like a real sort of dead space at the end of the probe. So if you were doing injections into sort of smaller structures or superficial structures, then that could be really sort of, much less sort of user friendly, really, and you potentially end up taking a much longer journey.
Is it worth just talking about, you talked about different probes there, and hockey sticks and linear probes, different types of linear probes. It's worth just coming on to talk about injections, and obviously that's another consideration when clinicians who are
that's true. Yeah, I was just going to mention, as Dave was saying, or as you guys were talking about the differences in the use of like hockey stick, because I would say that for most applications, even the hand, I'm actually quite happy with a linear array with lots of standoff and gel, and I think that actually is quite nice because you can see like the whole landscape of things. But I think if you start injecting, let's say, a DIP finger joint or something, which is quite small, then I think, honestly, without a hockey stick, it's actually very difficult, I think. A hockey stick makes it a hell of a lot easier. The small run up, and I'm sure you've used, Stu, in radiology, there's definitely a huge benefit to using them, aspirating small cysts and
yeah, no, absolutely. And obviously you get needle viz a lot quicker because the edge of the probe as well sometimes is not as broad. We've had a question from Nav, who's a podiatrist. Thanks for joining us, Nav, and thanks for sending a question in. So he's just said, would you say a linear probe would suffice for podiatric use? And if so, what frequency range? And I guess we've kind of touched on this. And I guess one thing I always say to podiatrists is think about the region that you're scanning, for one. And the key thing with that is you're lucky in some ways, because a lot of the stuff that you're scanning is very, very superficial. It's a fantastic area to look at with ultrasound, actually, in terms of anatomy and getting really good resolution images. So you can actually use almost as high as you can go with a linear probe, I would say, in terms of frequency. You can really be pushing your frequency quite high.
The only thing there, Stuart, is that I think you have to be conscious that should drive podiatrists towards the higher performance portables, because they will get more out of the higher performance systems than low performance, because low performance, the cheaper, less expensive systems really have quite limited near field resolution. They're using lower frequency probes, and the processing power in these systems is not really high enough to give a really high resolution image. And yet a lot of what a podiatrist practice is very superficial. Counteract. Exactly.
You know what I'm going to say, don't you?
I do.
You mentioned about superficial tissues, and everyone says, oh yeah, it'd be great to look at the plantar fascia, it'd be really superficial. But actually, it's a bit of a pain to visualize really well, because the sole of the foot is very thick, the skin is thick, you get a lot of attenuation when scanning that region from the plantar aspect of the foot. So actually, you need to be able to drop your frequency a little bit to get that penetration. So that's, plantar fascia is a key thing, I know, for the podiatry people out there.
Counteracting that, if you just want to scan plantar fascia and only plantar fascia, then a less expensive scanner is probably quite good.
Yeah,
quite adequate.
Yeah, absolutely. And also, again, all of the points that we've mentioned about learning, getting access, something that you can scan with regularly around, we talked earlier about handheld laptops, which, where do I go with it? Again, all of that's very relevant again, isn't it?
Yeah. But also, Doug, don't you think that, let's say for podiatrists that just want to have get an idea if there is like osteoarthritis at the first MTP joint, want to look at a plantar fascia and not really go into like massive detail for like nerves and sort of other kind of more complex structures, then I think probably a cheaper model is probably reasonably adequate. Depends what you kind of want to use it for, I guess.
I think so, but on the other hand, listening to what podiatrists do, a lot of podiatrists do things like tibial blocks, for example, and there would be a benefit in having
of course, for injections,
visualization, and for injections and that sort of thing. I think that to me, there's so much potential for ultrasound in podiatry, because podiatrists are also interested in Doppler. They deal with a lot of diabetic work, and I think that there's a possibility of really extending, that there's value in that as they build up their skills and experience. There's potential there. A lot of podiatrists use pocket Doppler, continuous wave Doppler devices to listen for the tibial artery. Well, you can see a tibial artery, banging great thing. You can also start to assess it. There's lots of potential there, I think.
Should we, I mean, in terms of, I'm conscious, there's a couple of things there. Doppler is another interesting thing that we should cover tonight in terms of Doppler sensitivities on systems and understand your Doppler. I just want to bring us back to the injection thing and kind of finish that one off and dot a few I's and cross a few T's on injections and ultrasound guided injections. Beam steer. What is it? Do we need it on a machine? Over to you lot.
I mean, I would say that When I first got beam steer on a machine, it's like having like a, you know, parking sensors on your car or something. You're like, oh my God, like I don't know how I ever did without this. And then, you know, I've probably been doing ultrasound guided injections now for about 13 years, and I would say year on year I use it less and less and less, and I rarely ever use beam steer now. The only time I might ever use it is if I particularly feel that I absolutely need to optimize, you know, for a very tricky injection and I really can't get the angle on it, then I might put a bit of beam steer on. But I'm talking, I might use it once every couple of days or once a week or something like that.
So when you say tricky injection, Dave, you're talking, just to clarify, a steep angle. So you're struggling to get your probe perpendicular to that needle. Yes, you're struggling to see it. Yeah. But also maybe you're just dealing with depth, and maybe just the nature of that tissue is more attenuated.
Quite deep, and there's, you know, poor, you know, it's quite a big hip or a big shoulder, probably more the case. You can't get the angle on it. You're really sort of, it's really difficult. Then you might sort of try a bit of beam steer just to see if you can get the needle a bit better. But I'd say other than that, I seldom use it.
Doug, are you happy to talk us through what beam steer is?
Well, beam steer is effectively, it's about rather than having the probe fire out its lines straight perpendicular to the face of the probe, it's sending them out at a slight angle. And that's possible to do if you think about a cardiac probe that does that. The problem is that you have, when you're sending out the ultrasound at an angle, that's not so much of a problem, but you're receiving the echoes back at an angle as well, and you lose a lot of sensitivity as a result of that. As you know, it's like the you know, light bouncing off the surface of a pond. In the sense that a lot of the energy coming back to the probe surface actually just gets reflected off. It doesn't go in. It's much more likely to come into the probe when it's straight ahead.
Yeah.
So beam steer has some value. A lot of you know, before you had needle enhancement programs, then beam steer was a way of enhancing the needle shaft because you could line that up better and you were getting some echo coming back to the probe surface. In fact, that's the way that most needle enhancement programs work. They integrate beam steering into a normal image and use that to enhance the shaft of the needle.
Yeah.
I would argue that it doesn't enhance the tip of the needle, and that tip is the bit that you're most interested in.
Yeah, and that's where you know, if you look at the evidence base actually around needle visualization and learning techniques, the key area actually for the novice is around the tip of the needle and visualizing that and actually orientating to the bevel rather than the shaft of the needle itself.
The tip of a needle scatters ultrasound. So if the tip of the needle is in the ultrasound beam, sorry, fireworks going off somewhere here. I hope it was fireworks, not gunshots.
Let's anyway. Work out which one of us have been visited by the police. Wasn't me. So.
But the point is that if the tip of the needle is in the ultrasound field, then there is always visibility of the needle tip. It will always give an echo. It may be very difficult for you to pick it up, which is why you move the tip of the needle and you rotate the bezel to actually help you recognize what is the echo from the needle tip.
Yeah.
You know, particularly for an angled injection, a steep angle injection, you don't need to see the shaft. What you need to do is track that needle tip.
Yeah, and I think when we think about needle visualization, I tend to agree with Dave. I think sometimes you can feel if you've got it on a system, you can sometimes feel dependent that you must have it on to see the needle. And I just want to say, I really want to emphasize the importance of the practical skill of probe and needle joining those two things up, I'm struggling to think of the words now at 10 o'clock on a Thursday night, but joining those two things up to actually be able to see the needle, it's that practical skill. And needle vision can help you with the things like Dave said, but it's not a quick way to see a needle. It's not as simple as put a probe on the skin, stick a needle in. Oh, but if you put your beam steer on, the thing will light up like a laser beam. You've still got to have the practical skill of getting the needle midpoint of that probe at the right angle, etc., etc.
Yeah, and I do think that you know, there's a little bit like your parking sensors or whatever. Rather than driving using your proprioception and your awareness, you start driving with your ears because you're just listening to the parking sensors. And I think there's a little bit of that. You start trying to angle the needle into the beam steer and try and fit it around that rather than actually thinking about what you're doing. So I think it's got a place in that very sort of like early learning or something like that, but it's like you take the stabilizers off us, in my opinion.
Yeah,
I'm a little more cynical than you about that, Dave. I think the problem about beam steering, about needle visualization, is that they often entrench bad habits, and you're better off learning without them, because then you actually learn what's real.
but I think, yeah, you're right.
I like it.
Curious. Should we move on to? I mean, I think we've covered. Stu Kerr said there. So, would you argue it's best to learn needle visualization without enhancement first? Okay, let's go around the room. Probably yes. From me.
It would be a yes from me.
Yeah. Yes. Yeah, I think so, but I think it has a place, though. I think, yeah.
So it's useful for those more challenging techniques. Dave, were you a yes or a no to that question? I think you're still on the fence there by looks of things.
Yes, for more challenging techniques, I think it has a place in the early learning, but do not become dependent on it.
Yeah, I'm a bit more militant.
Yeah. And I guess there's someone's just said here as well, Harry Harran has just said on Facebook as well, he said needle visualization is overrated. What's more important is target and injectate. Yes. Yeah, so you need to be able to scan basically to do an ultrasound guided injection is what we're saying, and absolutely, that's why we always that's always our mantra. Certainly, is that you've got to be able to scan something, see a structure, keep it stable, and then put your needle technique on top of that.
Yeah.
Shall we move on to Doppler? Doppler in machines. We're going over time a little bit here, but Doppler on ultrasound systems. My experience is it's hugely variable. And if you're using it in your practice for something like in a rheumatology setting for synovitis, or you do a specific tendon clinic or focused tendon evaluation, and you can for vascularity in a tendon or whatever, you need to understand your Doppler. Doppler varies so much on systems. Doug, probably best to start with you on that one, I would imagine.
It's a minefield. I mean,
yeah. Can you give us a brief 3-minute synopsis?
3-minute brief? Me?
Come on. Yeah, quick.
No, I think the thing that you just said Doppler, and the problem is that in MSK practice,
Doppler broadly,
in MSK practice, you're only really interested in one particular flavor of Doppler, and that is power Doppler, because you're not interested in, you're not interested in quantitative analysis of how blood is flowing in a blood vessel. What you are interested in is small capillary flow patterns, small vessel flow patterns, neovascularization. And power Doppler, which is simply looking for a Doppler signal, is the tool to use because it is sensitive to flow in small vessels. And the settings that you use for that are very important.
Yeah, and they're complex on there as well.
No doubt that higher performing, higher capacity electronics, in other words, the more expensive machines, have better power Doppler and better ability to display small vessel flow patterns.
You just ruined my next question, Doug.
Sorry?
You just ruined my next question. That was my next question was, do you pay, do you get what you pay for when it comes to Doppler? So yes, you do, is what you're saying.
You do, but you also have to be, to a degree, I think, to a degree more than any other aspect of the machine, you have to be reliant on the supplier making sure that the settings are right.
Yeah.
That's really, really important for this, because if you don't have the settings absolutely right for Doppler and power Doppler, things such as the PRF, pulse repetition frequency, and things like that, the gain settings and the carrier frequency, then it can all go severely pear-shaped. It's very easy to, by not knowing what you're doing, by having the settings wrong, make a wrong interpretation.
Yeah, you can overcall it.
And undercall it.
Stuart, do we have a minute to just, because I know this was a conversation that we were having earlier, just to prove that we do actually only ever talk about ultrasound. It was a conversation we were having earlier, and we were talking about sort of, the sort of like the aftercare or whatever that you get when you're buying an ultrasound machine, particularly for somebody who's just sort of starting out in ultrasound, and how important that can be. Is there anything that you can sort of want to say about that, Doug? Because I think that was some really interesting points you were making earlier.
I've got a couple more questions that have come through as well, by the way, as well. We might be here till Friday morning at this rate. Go for it, Doug.
Well, I think, if you think about it, the scanners come through, when a scanner is shipped from the factory, it comes with what are known as factory presets. And the factory settings are strictly average. And they're not really tailored. Now, remember what I said about scanners being made for a multiplicity of purposes? So, actually making sure the settings are fine-tuned is really important. And, scanners will come through with, in inverted commas, an MSK setting, but it'll be a general MSK setting. The world, people, practitioners get paid for putting a probe on someone. They get money for doing that, and they're not that interested in particularly with the cheaper machines. And the people who buy the cheaper machines, they get paid for doing something, but they don't. It's not actually that important, because what they always do is refer on anyway. So there's an awful lot of over-examination in a sense. So, a GP will use, in many countries, will use an ultrasound scanner. It'll build up and build up and build up. So every step along the way of a patient's journey, they'll be scanned.
So what you're saying is that you should get that. You should get that. You receive your scanner tomorrow morning.
It should be
on your door. But then there's a whole nother level of support on top of the factory preset and factory settings that you should get support with to try and really get the most out of it. And we've seen this on courses. We've had a whole range of systems on the courses. Some have been optimized to the max. Some haven't been optimized a huge amount or changed their settings. And the difference is striking at times between, and I walk around groups teaching and you see it, hang on a minute, that's the same machine. But that's not been optimized, and that one has been optimized. And it's not always about software updates, it's also about the fine tuning. And something you're particularly good at, Doug, is drawing out those extra bits of yardage around these scanners and things. Yeah.
And the reality is that a lot of that comes down to because practice varies around the country, around the world, but it's about drawing out and making sure that a machine sings for someone.
Yeah.
That's there is a lot of variability there, and some organisations just they have take an application specialist. An application specialist who's trained in cardiac scanning, because that's what they spend most of their time doing. If you bought a machine for MSK scanning from a company that sells a lot of cardiac scanners, then are you going to get someone who can support you with the real experience and skills that you need as an MSK practitioner.
Yeah, yeah.
Are they going to be able to set that machine up for you properly?
Yeah, yeah.
But also, Doug, like, sorry, just you know, because I totally get that, and I know from what you've done for some of the scanners that we are using from you, you know, is amazing and makes such a difference. But at the same time, I think a lot of people who might not have that sort of backup would kind of also be keen to almost have something that can work really well, sort of out of the box without doing, you know, like there has to.
No, it would be lovely. You know, I wish, you know, and I suppose I'm going to personalize this a little bit. I've tried not to do that this evening, but that's the reason why we focus on MSK. You know, the relationship works both ways. I bring you machines because I want to learn how good and capable they are for what you are really skillful at, which is MSK ultrasound as a group. So I will bring you machines and ask you, you know, and work with you to see if I can get them to work well for you. And there are machines I can't do that with, and there are machines that I can do that with. And then there's also the cost element.
Yeah,
I bring you machines at different prices so I can build an understanding. So we can build an understanding of, you know, if you're going to pay £10,000 or less for a machine, what is the best machine that you can get?
And what's the difference? What does it look like? You know, what's the difference between them as well? You know, I'm just going to just refer to a couple of questions we've had come in. So Romain said, what brand model would have best power Doppler sensitivity? Oh, you've launched an absolute corker there at 10 o'clock on a Thursday night. I don't think there is necessarily, but I think what you say, what we mentioned earlier about, you know, more expensive the machine, it tends to be the better or more reliable the Doppler is, I think. However, there is a huge amount of ability to optimize your machine around this, but you've got to understand your settings, otherwise you'll overcall and undercall Doppler settings. Anything else to add to that, guys? And
it's got to be set.
This is like a quick fire round, basically. Holding a quiz. Jackie said, don't know if I missed the discussion, but what about hockey stick probes for feet? Yes, absolutely. But because they're a smaller footprint, and sometimes you can get obviously small structures around the foot. I'm thinking of things like plantar plates, maybe if you're going to injecting things like Mortons. A hockey stick probe is really nice to use compared to a linear probe.
There are good and bad hockey sticks.
Yeah, exactly. That's my next point. But one thing some hockey sticks, you go to them and think, oh, it's going to be a hockey stick, it's going to be high frequency. It doesn't perform as well as you want it to. That's certainly the case that we've seen on a number of courses. So you need to, again, be thoughtful about what sort of hockey stick you've got.
And a hockey stick is also an expensive probe.
Okay.
You know, good hockey stick will cost you a minimum of £7,000.
Yeah.
End of. There aren't many. Hockey stick is quite a specialised probe. There aren't many manufacturers of that array, and there really are a very few good ones.
Yeah, yeah. Okay, I think that's probably most of the questions. Looking through, yeah, I think that's most of the questions probably so far this evening. So. I guess, guys, you're sort of. I mean, is it worth us doing our own sort of little top tips about, you know, purchasing machines as I kind of go around the table? I mean, my thing for all of my experience, and the thing I always say to people is get out there and try a range. I think, and support care is incredibly important. Try out machines is important. That's why on the courses we often have a range of systems so people can actually physically try out and see what the differences are. Understand the differences much more than just looking on a website or whatever. That would be my top tip. I think try them out. It sounds obvious, but
yeah, absolutely. I mean, I'm not sure if I have a lot to add to that. It is about, like, you know, like selecting from a number, and there is, you can't. It's like everyone's like different people like different types of you know, like image quality and stuff,
Yeah.
and certain people like go for something that, you know, you might think is not such a great you know, picture. So I think you have to it's very individual. So it's almost, yeah, you can't really say, well, that is it. Just try
Well, sometimes
work.
images, we haven't touched it, but ultrasound systems and manufacturers and brands have different tints to their image as well. It doesn't always, and sometimes that just suits you better than another tint for some reason. I don't know why that is, or but there's something in that as well, I think.
Yeah. And I think
it's a way. Dave, sorry.
I was going to say, yeah. I mean, there's the whole of that, and then there's the whole sort of, you know, the knobs and buttons sort of side of things. You know, I work in, you know, pretty quick throughput, particularly when I'm doing, you know, ultrasound guided injections, and I like a machine that's pretty easy, that does a lot of the optimization for me. I only sort of like, you know, have to twiddle a few knobs and buttons between sort of patients, and everything else pretty much sets itself, and that suits me down to the ground. Whereas other people like to have lots of knobs and buttons and everything to sort of fine tune. The only thing that I would say about that, and this is my experience of it, is if you've got a rubbish machine, there's no point. It's like having a, you know, a tinny little stereo and a massive graphic equalizer. You're just going to spend your whole time trying to make a half decent sound out of it. Okay, if you've got a really powerful machine with lots of processing power and this, that, and the other, then it's worth having all the sort of fine tuning. But I do think if you've got quite a, say, cheap machine, quite a simple machine, it's sometimes worth thinking about going for one that doesn't have quite so many things to adjust on it, and equally things that can go wrong, but you spend less time just trying to give yourself an adequate picture.
Yeah, I think that's a very important point there. Again, scanners tend to be quite complicated because they are designed for multiple tasks. And actually, if you're interested in MSK, what you want is something that just does what you want it to do. And simplicity is really important in that. And it's you know, there's a magic to this, but it's also a connection in the sense that you actually have to look at a number of machines and decide for yourself which is the one that fits you best. An image setup is really important in that. Companies use a certain style of image to keep the customers that they have and make it difficult for customers to leave that image setup. And also that they want to make it so that other companies, people who are not familiar with it, there's the counterbalance to that is that if they make it too much so that they don't lose their customers, then other people who've not learned on that equipment may find it difficult to accept that equipment. Mm-hmm. So the net effect is that in any particular market, the products that are most popular are the ones today, are very often the products that were most popular 20 years ago, mm-hmm. because they feel familiar. And it just makes it very difficult once a pattern is set. The key there, that can make companies quite lazy in my view, because they don't actually have to work very hard. And the key is, in this stage, where I think in MSK Ultrasound, an awful lot of people who want to learn, is to look at and check out at courses which companies support the courses very well, because if they support the courses, they're likely to support the customers as well.
Interesting point.
Mm-hmm.
We've got another question's come in from Nav again. How do you know if you've already got a good machine? He's got one. What sort of things? He's already got one. What sort of things should you look out for? I guess the key thing here is about thinking ahead about what you're going to use that machine for. This is just my opinion, and you guys might disagree with me. We're going to use a machine for, but also thinking about actually then what sort of image quality you're going to get for those particular structures that you need to be looking at for whatever you're going to do. If you're going to be doing joint evaluations for erosions, you need a really good reasonably high frequency system that can show you the cortical outline of joint quite accurately. If you're just going to be doing an evaluation of a joint to do an injection, and you need to predominantly see the capsule and the joint margins without maybe the finer detail, if you like, then it might be slightly different.
Can I again just bring us back to a point just quickly? I know we're going to talk about this sort of thing in more depth in a couple of, when we do the governance session. But it's an interesting point, again, that I get asked, and I'm sure you get asked it as well. And that's where people are thinking about actually sort of charging for imaging. So they're actually going to use their ultrasound machine as a sort of diagnostics service. And what is the sort of minimum spec, or what is the guidance around sort of minimum spec if you are going to actually sort of market yourself as a sonography service?
Yeah, I think if you, I think I can answer that one, and don't quote me on this fact, but I think there is some documentation out there by the RCR around minimum spec for MSK probes, not systems, probes, 6-13 frequency for a linear probe for MSK is the minimum spec. I'm not sure there's a minimum spec for the system. And if you think back to what we've said already about the probe actually usually attaches, or most of the time attaches to a processor, there's a key part there that maybe also needs to be considered as well. Yeah.
Interesting point though, isn't it? Because somebody might, if you are sort of as a diagnostic service, and let's just say, an extreme, you were using like just a handheld probe, but you were, charging £250 a scan and marketing yourself as a diagnostic sonography service. What is there to stop you doing that? And what's the governance around it? But anyway, I know we're talking about this sort of thing in more depth another night, but it is
sort of conversations you're going to keep you up all night, isn't it, Dave?
Yeah.
Well, I think again it comes down to competencies, and it comes down to also, if you think about an AQP service, if you're going to offer a diagnostic service like that, then you've got the Care Quality Commission involved. You will have, if you're pursuing AQP, which can cover MSK, then you've got to make sure that the images are being reviewed.
Absolutely.
And so that makes a connection to radiology supervision probably as well.
And actually, I think that draws us into kind of, you should be a TV presenter, Dave, the way you've linked that to the next episode. But that sort of brings on to the issues around governance and stuff that we're going to try and sort of discuss next week. And I might see if I can twist Doug's arm actually to come back and join us for things like quality assurance and probe health and things like how do you know if your machine is not working as it should be? A lot of people I don't think are particularly familiar with that, as critical as it sounds. So we're going to touch on some of those issues next week from a governance perspective, and I think that should be quite interesting. Infection control and cleaning probes, all of those kinds of things as well. And on audit, which we just kind of touched on there, you should be auditing images, etc., etc. So I think what I'll do is, are we all happy to sort of draw that to a close tonight? No one's going down the pub anyway, are they? So I think we can probably, I think we can probably sort of draw this evening to a close. But thank you so much, everybody. We've had loads of people watching. We've had loads of questions coming in, which has been fantastic because it makes it so much more interactive for us. Big thank you to you, Doug, for coming along with your expertise. It's given it a lot more depth and a lot more breadth than certainly the three of us could have put together. I think they'll agree.
Pleasure.
I think so.
Absolutely. Where would we have been without?
Yeah. Yeah, so guys, this will all be on the website next week. There's a tab at the front on the homepage of the website for MSK Ultrasound webinars. This will be on there. It'll also be hosted on YouTube. And if you're out and about doing your daily walk, whatever at the moment, then this will be on Spotify as an audio file for you to listen to as well. And hopefully we'll be getting onto iTunes at some point as well. So thanks very much. We've really enjoyed you. So there's a few guys.
Can I just make one thing and just say, look, if anybody wants to contact me privately, directly, or anything like that, then you can do that through my email address, which is douglasogg@orcamedical.co.uk.
Perfect.
I mean, I know that you can often pass you often pass these details on anyway to people who are in.
So if you've got a particular question and you can't get hold of Doug, then email info at the ultrasound site, send the thing into the website, and I will forward it on to Doug, no problem whatsoever. We've got a few things coming in, which is great to see. Jackie, you're in Melbourne. Wow. Thank you so much for joining us. Yeah. Early hours, she says. But brilliant. Thanks so much, guys. We'll be back at 9 o'clock next week. Keep your eyes peeled for news about that during the week, and we'll look forward to seeing you all then.
Cheers.
Thank you very much.
See you next week. Bye-bye.
Thanks. Bye.
Bye.
Bye.